Thank Brian and PHI.
Sorry.
I want to thank Brian and PHI and the PPS community for inviting me today to say a few words. Do my best to answer some questions that you may have and give you a little bit of the background that I have in working with this population and here in Warren, Michigan, under the direction of Dr. Daniel Ryan. If I don't know if you guys know Dr. Daniel Ryan, but he does run the post-polio clinic out of the Center for Physical Medicine in Warren, Michigan. And I've had the pleasure of knowing Dr. Ryan for probably about 15 years now and working directly with him in his building for about 10. So this is my first experience doing this with PHI, but I certainly, you guys can pick my brain as much as you like. Hopefully I have some answers and some insight for you. I know most of the people in this community probably are very familiar with post-polio syndrome and poliomyelitis and its origin as the virus. And maybe I can just add a little bit, give you a little bit of insight from the physical therapy standpoint rather than just from the ask the physician standpoint. In any case, just to give a little bit of background, because I don't know exactly who my audience is today, other than I'm guessing a fair number of people that do actually manage PPS. And then maybe there's some students, maybe there's some caregivers, maybe there's some family members. So I'm just going to give a just very brief background on the polio virus and then post-polio syndrome. If, if anybody has questions on that, please feel free. Basically, poliomyelitis is a virus that affects the motor neuron. The motor neuron is a nerve that controls the motor unit. The motor unit is the nerve with the muscle cells or fibers that it affects. What ends up happening is that virus is self-limiting. It's a virus. So it ends up damaging the motor neuron, and then the motor unit is no longer able to function the way it normally did. So fast forward that, we developed a Salk vaccine in the mid 20th century. People had very good success with the Salk vaccine. We in the United States and North America seem to have eradicated new cases of poliomyelitis. Until recently, we found that there are some variant strains coming from different areas, maybe underdeveloped countries, that kind of thing. A few pop up in the United States. But for the most part, we thought we had it pretty well eradicated. But that said, then maybe 2 to 4 decades later, people started to reemerge with symptoms. It wasn't an active virus at that point. It was really the late effects of the original virus or infection. So what ended up happening is people started finding weakness or joint instability and things like that that seemed to mimic what was happening with the actual polio virus. They started to investigate this, and it's really kind of a diagnosis by exclusion. They determine, okay, the patient's having these problems. Let's make sure that it's truly this, and they try to exclude, or as they diagnose, they try to rule out certain other neurological conditions. But practitioners that do this for a living, your physiatrists, your neurologists, they all are very, very well versed in diagnosing this now, because it is I wouldn't want to say common, but it is common to this population, and they do diagnose it very effectively. That said, what my role is in physical therapy is I come in and I treat neuromusculoskeletal dysfunction. I'm sure many of you have had experience with a physical therapist. I had some pre-submitted questions. Some of those questions indicated, hey, I saw a therapist, said that they were familiar with this, and my experience is maybe they weren't quite as familiar as I'd like them to be. So do you have any other insight for me? Well, certainly happy to share what I know. And like I said, I've been around the block a few times with Dr. Ryan and seen many of the population I should say in Michigan. And it's given me a fair background. Like I may not have seen every single complication or situation, but I've seen quite a bit. So that said, my role is trying to figure out, okay, how do I help this person in the neuromusculoskeletal realm? So I look at it, I round with Dr. Ryan when he has these clinics. And then what we do is he generally brings in a multidiscipline approach. So we'll have the physician, we'll have the physical therapist, occasionally occupational therapy. We'll have orthotists, prosthetists. Sometimes we'll have a neurology specialist, that sort of thing. And then we all go through and we discuss these cases, see, well, what does this patient really need? And then I might actually just suggest right at the time of meeting the patient, hey, we did an evaluation. We see that X, Y, and Z needs assistance. Maybe they need, an AFO or a KFO, or they just need some mild instruction and simple exercises. That can be taken care of right then and there. But then at other times, Dr. Ryan will be like, this is somebody I'd like you to see in therapy. So then I'll see him in therapy, and they'll spend some time with us. And then my job again is to figure out, well, what does this person's day look like? How can I help them functionally? So are they having a hard time like getting out of their chair and then maybe going to the restroom? Are they having a hard time with reaching for something in their cabinet? Whatever it may be. So then we break that movement down and try to figure out, okay, how do we help this person? Keeping in mind that with post polio, it's a little bit different than treating any other population because you do have fatigue on the neuromusculoskeletal system. You can't treat it in such a manner that you're going to fatigue it further. It doesn't make sense. So you may have heard no pain, no gain in exercise, but doesn't hold true with the post-polio syndrome population. It really should be no pain, no fatigue. So that's really the direction that we try to go and try to manage. So I'm probably going to be overlapping quite a bit of the questions here a little bit because I had the opportunity to preview the ones that were submitted today and then the ones that were submitted on Friday. By the way, I do want to apologize to anybody that did show up on Friday. We had some technical issues with my camera, which our IT department figured out today, and so we're back online. But if you did show up Friday, my apologies, and I'm glad you're back today. But I did have a couple of questions submitted Friday, and I went through and reviewed those, and I feel I can give you a pretty good answer. And then a couple more were given today where I can give you some pretty good insight, but they do overlap a little bit. So if I don't specifically touch on your question, then let Brian know, and then he can convey that to me, and then we can get this answered for you. So that, without further ado to that, I think the population that's here probably really does know post-polio pretty well. I think we briefly described it where, basically you have the motor neuron has dendrites. And not to get too technical, maybe a lot of you have already reviewed this, but the motor neuron has a body to it and then an axon, and there's dendrites. Dendrites are things that kind of sprout out and communicate with other cells in the area, and also with getting the action potential to the muscle unit. So what ends up happening is with post-polio syndrome, we find that the original motor neuron that was involved in controlling a certain set of muscle cells fatigues, burns out, gets damaged by the virus. So then what happens is the dendrites are grown. There's more dendrites, or they believe. There's not a great theory on this yet, but this is what they think is happening. More dendrites are grown from the axon or from the cell body. It connects with more muscle units. And then, as you can imagine, if you were asked to do a job where you took on 5 or 6 other people's work, you're going to be fatigued by the end of the day and wear out as well. So that's when we started to see a reemergence of the symptoms, because those motor neurons were now wearing out or fatiguing. So that said, people had a reemergence of the symptoms, and then that's when our role comes in to try and figure out how do we best help you. So my experience, I've seen people where they've had leg length differences. That's also what we do. And when we do our evaluation is we figure out what comorbidities does this person have. So besides having post-polio syndrome, do they have comorbidities that are going to affect our rehab in terms of cardiovascular health, joint instability? Maybe they have a leg length difference. There could be a host of other things that we have to think about. That said, we try to encompass it all and come up with the best plan. But to touch on it a little bit, to say with post-polio syndrome, it comes down to trying to do the best work for that particular situation and that function without overtaxing or fatiguing the system. That's what it really comes down to. And maybe clinicians that aren't quite as familiar with the syndrome, they see muscle weakness and they're like, well, how do we deal with muscle weakness? Well, in this population, we exercise and we give them progressive overloading exercises. Absolutely the wrong thing to do in this population. It's really more about stretching, mobility, joint preservation, energy conservation. That's really what it comes down to is plan your day, plan your movements. How can we get what you need accomplished done and do it where you're not overtaxing the system? And you do that by thinking, as a therapist, you think about what's my dose of exercise for this person? And dosing of exercise means what what load am I putting on them? So what kind of weight, or is it just body weight? Is it external weight? Is it bands? Am I asking them to absorb ground reaction force? So is it something where they're accepting more weight on their musculoskeletal system because I'm asking them to go up and down stairs? You know, if you climb stairs, it actually exerts 3 to 5 times your body weight on your system. So people don't realize that, but just climbing stairs can be a very difficult exercise, especially for the limbs affected by post polio. For your spared limbs, for your other limbs, 100% we can do a reasonable strength training program, but reasonable. Again, you don't want to go crazy and cause significant discomfort to a joint that you're depending on because your other joint can't handle the load. So it doesn't make sense to go crazy with it and to treat you like maybe a young athlete or a teenage athlete or something like that. You're an athlete. You're a life athlete for sure, which means I need to think of myself as running through a marathon, and life is that marathon. And basically, if I'm in the last couple of minutes of that marathon, uh, you wouldn't do something silly and go sprinting for the last 3 minutes of that marathon. You'd probably pace yourself, make sure that you can finish. And then after you finish, you go through a cool down and you manage your symptoms, you manage your fatigue. And that's the same thing with post-polio syndrome. You really need to manage symptoms. I hope that gives a little bit of background, a little bit of insight to people that maybe are just visiting, and maybe they have a caregiver, they're a caregiver, or maybe they're a family member or something, they're a student, they're just trying to learn a little bit more about how we manage this population. Now, if we want to get into a little bit of exercise and things that we do to manage post-polio syndrome, when you're talking about your affected limb, which I think most of the discussion is probably going to be about that, but getting into a pool is a great environment. Pool will unweight you. We can offer you things in the pool like flotation devices, things that will help assist the movement we want, not hinder it, but assist in it. Just getting into a pool and walking is a very good exercise. Now, the depth of the pool is going to matter. You know, you might do a little bit better in a more shallow pool. It's a little bit easier to walk in. But the depth of the pool you go in, if you're just going to float, the deeper you go, the more buoyant you are and the less weight is on your body, which is great too. The other thing with pool therapy is you generally want to keep it warm. Don't get in a cool pool because a really cold pool is going to fatigue you. A really warm pool will also tax you. So shoot for like 90, 94 degrees when you get into a pool. And practitioners that treat in the pool or water-based therapy, they should know that. So you guys should realize that. But if you're going to do it on your own, you have a pool access available to you, 90 to 94 degrees is really where you want to be. In terms of exercise in the pool for both your affected limb and your non-affected limbs, basically your affected limb is going to be about gentle range of motion, gentle stretching, gentle movements, non-fatiguing. If I tell my patients, like, after we're done with therapy, you should feel somewhat worked, but reasonably, where you feel good about how much fatigue you feel. If it's excessive, like if you're still tired 60 to 90 minutes later, it was too much, we got to back it down. And your clinicians should know that, because we're there to help you. We're not there to fatigue you to the point where you can't function for the rest of your day. You might see us for hour and a half, 2 hours, whatever it might be, but you still have the rest of your day to function in, and then your following day. And if you've been worked so hard that you can't complete the rest of your day, or you feel overtaxed the following day, then that's a signal to clinicians and to your caregivers that you need to back that down, even to yourself. I know a lot of people generally want to push themselves a little bit too, and you can do that to an extent, but you within reason. You have to be very thoughtful in the fact that you are your number one advocate. You're your best advocate. Nobody owns this body but you. So nobody's going to be as interested in preserving it as you are. So you should use your voice, and you should be very forward with not only yourself, but also with people treating you, like, hey, this might be a little bit too much for me. And I'm significantly fatigued, an hour and a half after I leave here. I can't complete the rest of the day, or I'm going to bed 2 hours early, or whatever it might be, or the next day you don't feel well. So it's well within your rights. Be your best advocate. Tell these people, yes, this is a little too much. You have very well-intentioned therapists out there, very well-intentioned physicians, but again, they don't live in your skin and in your body. So you're the one that knows your limits. You're the one that can tell them, like, hey, this might be a little more than what I can handle. But on the flip side of that, I've talked a little bit about what you want to avoid. What you do want to do, again, when you're in that pool situation, it's a matter of helping your affected limbs. Like I said, again, the pool is great. The flotation devices help move it. For instance, if I had a patient who was spared, like in the extensors of the hip, but they're really compromised in the flexors of the hip, I might put a flotation device, a very small one, at the back of their knee and help them to go into flexion, because it'll help float them into flexion. But then they use their extensors, which are pretty decent, to then walk through the water and to actually drive their leg back down, and so their foot is on the pool bottom. But then again, with you have the ability to hang on to, like, maybe the wall of the pool, or if you're in a pool that has ropes, you can hang on to those ropes if you like. And you can do simple things like an assisted heel raise, primarily with your non-affected limb, but your affected limb can go through some of the motion as long as you're not overtaxing it. Again, so you're the best advocate for that, to tell people if it is being overtaxed. Now, out of the pool environment, if you're going into a land-based training facility, like if Dr. Ryan refers me a patient into physical therapy here, it's an outpatient physical therapy clinic. Some clinics do have unweighting devices where it may be over a treadmill, or they have an I-beam in their clinic, and you put it on a harness and you're unweighted. So we can take your body weight down to, maybe 20% of your normal body weight, and we can walk with you. And it's generally very safe. People aren't going to fall in that situation, so because they're being supported externally. It's very, very good to do that type of unweighting, because number one, it does help offload joints that are sensitive. It does help with fatiguing muscles. It does help with people's confidence that something external is helping me. And so you can build somebody's confidence, and then over time, add more and more weight to what they can handle and what's reasonable. And then I also sometimes will use it in terms of gait training. So if I use, or I always use it for gait training, but I use it in terms of gait training with maybe a new assistive device. So like if this patient's going from, let's say they are used to having a rollator, but they would like to try a cane for a special occasion. I recently had a patient say, hey, I would really like to walk with my daughter down the aisle, because their daughter was being remarried. And they said, I really like to walk with my daughter down the aisle. I don't want to have to use a walker. Do you think we could practice using a cane? And this person was high functioning and functioning high enough that I felt we could do that. So with some of these techniques in this practice, we were able to go ahead and do that. And they were successful. Their wedding was actually this past weekend. So, and they were able to walk their daughter down the aisle, which was nice. But that said, in terms of some of the questions that were submitted, I can roll through some of these from Friday, and then maybe get into some of the more recent ones that were submitted today, so that we have some time to answer those. And then if anybody else has a question in the audience, that'd be great. If all of this is like completely review for you, which I'm assuming for many of you it probably is, please indicate to us, and I'll try to move on to something that might be a little more interesting to you. But that said, so Brian, if I'm rushing through anything too, let me know. If you have a different direction you want me to go in, let me know.
Sure, no problem. And again, if he is on your question, feel free to unmute yourself if you have anything to add, or if you have a quick follow-up question to what he says, it's fine.
Yeah, for sure. So, and I apologize, everybody. When I first started, Brian gave me a great introduction about my history and everything. And I've been a physical therapist. If you haven't guessed, I've been a physical therapist for 25 years. So I've been around for a little while. And I know my introduction, it was actually the one that I used at Team Rehab and for my bio. And it does, we have an outpatient clinic. So naturally in the outpatient setting, we do have a lot of student athletes in the area, a lot of outpatient orthopedic conditions. Probably the most prevalent orthopedic condition in physical therapy is low back pain, right? So I think 90% of Americans are going to experience low back pain in their life. And that doesn't mean that post polio isn't going to. Most of my post polio patients did have back pain at one point or another because some of their trunk musculature was weak and respiratory muscles were weak and that sort of thing. But anyway, so that bio does kind of cater a little bit to the outpatient realm. But like I said, I've worked in acute care hospital settings. I've worked in outpatient physical therapy. I've owned a clinic. I didn't put that in the bio because it's team rehab. And so I've owned a clinic for 7 years and in Rochester, Michigan. And I did great with it. I thought it was awesome. But what I realized is that when you own it, you are everything. Your IT, your HR, your marketing, and you never see your family. So in that respect, I said, I did this to better my family, but if I'm never seeing my family, are they really better? So I decided to sell it to another company, and I'm happy that I did because I could spend time with my family. But that said, Dr. Ryan then asked me to come over here, and that's why I've worked with him for the last 10 years. So that's been a blessing for me because I did know Dr. Ryan from working at one of the major hospital systems. And then he was gracious enough to invite me to come over to the physical therapy clinic here in his building. In any case, I have a question from a Friday from Patty Parker. And Patty's question, I'm going to read it aloud so everybody's on the same page. She writes, with my affected leg, should I be careful not to overdo it in the pool? How ironic. We just talked about that. I know I shouldn't do weight-bearing exercise with it, but I try to exercise the good leg on land without using the affected leg too much. So, Patty, I would say to that, kudos to you. You're doing exactly what you should do. You're being conscious, you're being an advocate, you're asking questions, and you're doing exactly right. When you're in the pool, I think it is a great opportunity, once again, for you to exercise both limbs, but again, within reason. Your affected limb is going to fatigue a little bit more, even though you're in a pool environment, and I'm painting the very appropriate picture that being in the pool is very good for your post-polio syndrome. It still will fatigue you. The more speed you try to use in the pool, the more resistance the water offers you, and the more expenditure you have in terms of energy. So I would still be very careful in the pool. I think it is fine for you to do pool work, as we've talked about. But yes, you should be very careful in the pool. Try to use those tips I mentioned. If you have a warm pool environment, it's going to be better for you. If you do things that are an assisted capacity for your affected limb in terms of using pool noodles, flotation devices, things like that, wonderful. You certainly can do very simple things like using pool noodles and flotation devices to float and gently kick your limbs. Again, within reason. Your affected limb can do more of the weight bearing. I'm sorry, your non-affected limb can do more of the weight bearing when you're in the pool if you're in a very shallow pool environment. So that way you're not overloading the other limb. But I think it's a great opportunity to exercise that affected limb. The rest of your question here, again, reads, I try to exercise the good leg on land without using the affected leg too much. And that's 100% appropriate. That is when you should do most of your exercise for the non-affected limb. So we don't live in the pool. The pool is a very good tool, but you live on land. So you need to train the way that you live. And so you can do things in the pool to help, but you really need to train while you're on land because that's the environment in which you live. And so with your non-affected limb, 100% okay. I look for these things in my practice is your limb, that's the more weight-bearing limb, the one that you view as your good limb. What joint range of motion does it have? What position is it in when you are in full weight bearing? Like if you're doing a swing through, that's when your non-affected limb is in full weight bearing. So is that joint in an appropriate position to accept that load and not be injured? That's kind of what I look for, because I by no means ever want your limb that you depend the most on to be injured in a silly manner. So if we're going to go through and do an exercise prescription for you, we're going to make sure that that limb is always cared for in the right way. It is exercised in the right way, so that you don't injure cartilage, you don't injure. Let's face it, most of the population that's dealing with this is older, right? You guys are in your seventh, eighth decade of life, sixth, seventh, eighth decade of life, and osteoarthritis is something that goes with that. So the longer you're on the planet, the more you're in a gravity environment, the more that cartilage tends to wear. And so when for the last 2, 3, 4 decades, however long you've been dealing with this, that limb is doing more work, just like your motor neuron does more work. It's eventually fatigues. So if that limb is doing more work, yes, the cartilage can wear, and yes, it can fatigue. So we do have to be very conscious of that as well. So always make sure you're communicating with any practitioner you're dealing with, and that you're not overtaxing that limb either, and that it feels good. You should leave therapy, or you should leave your exercise prescription thinking, hey, I've done some good here, not like, hey, this really is bothering me. There are times where we'll do an exercise and it just doesn't agree with you. Maybe it worked for 10 other people, but you're the one person that it doesn't work for. Then we have to put our brain power together and say, okay, well, what else can I do to accomplish this task and not exacerbate that joint? So that's kind of where our bread and butter is. We try to figure those and solve those questions. So let's see if I've answered your question thoroughly. Let me just read through this one more time. I think we've touched on it all. You want to, again, prioritize your movements, prioritize like, hey, like this is how I should accomplish this task. And if for some reason it doesn't feel right, then by all means, there's another way to accomplish it. There's always another way to do it. So just have that discussion with anybody that's treating you, or if you need to reach out to somebody, certainly reach out to your practitioner and ask them those questions. So hopefully, Patty, I hope you got some information from that question or from that answer. And then my next question from Friday was Nick Gomez. So Nick wrote, I've been to several PTs who claim to know about post-polio syndrome, but all the exercise I've been told to do have created further problems for me. What are some of the safe exercises that won't create further problems for my legs and arms? So, Nick, that's a tough one to say just over the computer. Without actually evaluating you and seeing where your deficits and needs are, it can be difficult. But I can give you a little bit more of a general answer, like I've been saying all along. I apologize that you've gone to practitioners that maybe didn't know quite the depth of post-polio syndrome that you needed them to know. But when you have a new physical therapist, or any practitioner for that matter, it is perfectly appropriate in your first meeting with them, or even before the first meeting, when you're on the phone scheduling the appointment, and just say, hey, does this person have experience with this population? I appreciate what they do as a therapist, but really this is a very select population. There are certain ways that you manage it, and you have every right to ask that. It's your body again. So nobody has a greater vested interest in preserving that body than you. So be your advocate and ask those questions. So right from the get-go, talk to that receptionist that's scheduling the appointment, and just say, hey, can you make sure you schedule me with a therapist that is very knowledgeable with this? And then maybe question that knowledge, because a lot of people, let's face it, will say, yeah, I got knowledge with this, but then maybe don't have the level of experience that you need them to. I'm not saying that they're misrepresenting themselves, but maybe they've had, a very high functioning post-polio person that maybe doesn't represent or reflect the needs that you have. So certainly you should ask those questions. But anyway, Nick, I would say this, in general, again, the overarching theme here is don't over fatigue yourself. Okay. So again, water-based exercises are great. Everything that I said up to this point would apply to you, Nick. I think, If you have access to a pool, it is a great opportunity to get in an unweighted environment. If you go to an outpatient clinic, or maybe you're enrolled in therapy now, and they have an unweighting system, that's a great thing to do. If they don't, then it becomes, again, about that dosing I talked about earlier. Dosing, again, is not only the load, but it comes down to the reps, the frequency, the rest breaks, all that kind of stuff, the length of time, the intensity. So what I would say, Nick, is low intensity for your affected limbs. You're going to want more range of motion, gentle stretching, things that preserve motion. You're not looking in this situation and with these limbs, you're not looking to go in there and say, hey, I'm going to get this limb this much stronger by this date. It doesn't make sense to put that kind of load on it. What you need to do is think about, how do I preserve function? How do I preserve what I do have? And then maybe in time, I can increase dynamic stability, maybe a little bit of strength, that kind of thing. But let's face it, it is, again, an over fatiguing syndrome. So don't overtax it. That's the main thing. Again, I'll refer back to the no pain, no gain. It's better in your population to say no pain, no fatigue, 100%. And then prioritize your energy consumption. Like if you feel that, hey, I really like to do this exercise, but it is somewhat fatiguing for me, then that day, maybe that's the only one you work on, right? And then it's perfectly fine to take breaks. Break that exercise up into maybe 3 parts where you take a couple minute break in between and then finish it. And don't feel that you have to run through the entire marathon at once. If you have to take a rest break, that's fine. And then come back to other exercises you're familiar with, maybe the next day or 2 days later, so that your body is not quite that fatigued. Again, I always refer back to the pool. If you have access to it, it's a great thing. So I know not everybody has that, the unweighting system, and then use some intelligence in the way that you put your exercise program together. Make sure that you're not hurting joints. Generally, if your joint is lacking range of motion, if it's not in the correct position, your body's designed to be symmetrical. So if it's not symmetrical, it's going to be weight bearing in a different position than it really should be in to accept those loads. So you have to be smart about, like, if I'm putting my knee in a hyperextended position all the time, is it really good on the joint? Is it really good on the ligaments of the posterior knee? So, you're probably stretching the heck out of the posterior ligaments. You're probably really compressing the cartilage that is left. I know in my experience, I've had a lot of post-polio syndrome patients that it's the only way they could ambulate, by snapping their knee into extension. And when they did, that gave them some sense of stability, because they're depending on the bone structure to support them rather than the ligament and muscle, right? But you have 2 forms of stability. You have, the actual passive structures, which would be your bone, gravity, ligaments, things like that. And then you have your dynamic structures that offer stability, which are your muscle tendon unit. And then in this case, the neuron that controls that muscle tendon unit. So if one is compromised, you're going to have to depend on the other one. There's probably no way around it other than doing bracing. Again, we touched a little bit on bracing earlier with like AFOs, KFOs, that kind of stuff. Some people have the drop block bracing and that kind of stuff. But all that stuff is designed to like support structures that maybe can't support themselves. And so that becomes important in the multi-discipline team that I mentioned earlier, where you have an orthotist, prosthetist there with you on the first day that you're being evaluated, and or maybe you've seen them previously and they've made some suggestions for you, but then your physical therapist gets the opportunity to kind of review that. And then if you have that information of who your orthotist, prosthetist is, bring it to your physical therapist so that they can then make contact with that person and then see what eyes they were looking at you with, and then they can kind of brainstorm things. But so Nick, it's always disheartening to hear that maybe you went someplace and weren't happy with the therapy, because I want every therapist to do great, because it just helps to advertise my profession, and I want all the patients to be well cared for. But if that person wasn't right for you, Nick, I would say search for one that is. And then the way that I would do that as a physical therapist, my advice would be this: reach out to PHI. Maybe they have a database where they have connections of people that they can put you in contact with, or reach out to your physiatrist or neurologist. They may have groups that they know are well versed in post polio syndrome. Your bigger educational institutions, your bigger hospital systems generally have people available to you. So reach out to those people, and then online forums. Certainly if people are in your area, they can maybe recommend somebody. People are very good at communicating, like, hey, I liked this guy, and he probably even better at communicating, I didn't like that guy. So I think that's a great couple places to go and try to find somebody that helps you. Just to make sure that I've answered. Again, safe exercises for you. It's tough to do without actually seeing you. But again, like I said earlier, all those principles that I mentioned, I did print off a couple of sample exercise programs, the things that I do with patients. And I just read through a couple of them, like just real quick, like some of the stuff, like, I don't know, again, Nick, I don't know how extensive you're involved, but if you have trunk instability, you have difficulty with like diaphragmatic breathing and that sort of thing, that becomes very paramount, because if you can't breathe, you can't do anything, right? So we don't want to see people accessory breathing, the platysmus, all these muscles up here. If you have labored breathing, people under duress, you'll see these muscles start to contract. We want to see people in your situation, diaphragmatic breathing. We want to see your belly rise and fall. And one of the ways I tell patients when they come in from the very beginning, make a triangle with your fingers, put it over your belly button, abdomen, and then just watch your hands move in and out as you breathe. That way, you're perfusing correctly, your diaphragmatic breathing. That's a calming effect too. All of this has been about fatigue and trying to preserve energy. When you're stressed or you're accessory breathing, it expends energy. So when we diaphragmatically breathe, we calm things down. And then when we calm things down, you have more energy in the tank to do exercise that's beneficial, right? So that's probably number one. Number two, very simple. I'll have people sit on a table. Maybe if they need supportive things around them, I may start with something supportive, lumbar cushions, that kind of thing. But then as they maintain strength and they understand dynamic stability and what I'm asking them to do, because sometimes it's just the communication. People have to understand what you want them to do in order to do it. So we'll kind of run through it. And if they don't seem to actually understand it, then I'll go through and sit down and show them exactly what I want them to do. But then they start to demonstrate an understanding, and then maybe we can pull some of the lumbar cushions away, and they're able to hold the position I need them to hold. So what I will say is, like, belly in and out, diaphragmatic breathing. Try to do an upright posture where you pretend that a string, or if you're a lady and you have a pony, or even if you're a guy and you have a ponytail, somebody's pulling your ponytail or the string that's attached to the back of your skull, pulling it to the ceiling. You'll see yourself go from a slouched posture more to an upright sitting posture. The back of the neck, the spine becomes long. You do a gentle chin tuck position. That position opens all the foramen in the spine. It helps to avoid any kind of impingement that you may have and may confound what we're trying to do with your exercise in terms of post-polio. If you have any other comorbidity like stenosis or anything like that, we're trying to open as much as we can so that you don't have anything else compromising the nervous system. And then it's also a very good exercise for stability of the core and pelvic stability, is you learn where is pelvic neutral. So I'll have patients, again, after they've done diaphragmatic breathing and they're sitting and they learn that string up to the ceiling position, I'll say, all right, now I want you to rock your pelvis forward and backwards. And those two extremes, if you rock all the way forward or you rock all the way backwards, are your full extended position and your fully flexed position. I want you to find the exact middle of those two. So you kind of feel it, and then you find where you think is the middle. And that's kind of where I want you to hold, because it's good for your low back pain patient. It's good for, if you think of your body as a skyscraper, if you have a good stable base, everything above it can then be stable. But if you have a crummy base, nothing above it is going to be really stable. And so that then carries over to, once we've done the table type of work, it carries over to when we're walking and we're doing things with, like, say, a rollator or any other assistive device. They understand that the stability kind of comes from the pelvis and the center of mass, and not to lean too far forward on their rollator. And one of the things that we always have to remind patients is, walking is kind of a progressive falling forward, and you have to catch yourself. Well, if you're not very good and you're not very fast at catching yourself, what's going to happen is that rollator gets away from you and then you risk a fall. Well, we don't want that to happen. So if you have a very strong, stable base, you can stay more upright, keep everything stacked, and then things don't get away from you. And then you're more functional in your vicinity or center of mass. Then it depends on how many weeks the patient's in therapy too. I might take them through some gait training activities where, yes, on land we do a little bit more with your non-affected limb, and we might do some like step over type drills and things like that, depending on, again, how involved is this patient and what is their fatigue level. So I sometimes, this little thing I use in therapy is I have a pulse ox that I use in therapy. I'm sure many of you are familiar with what a pulse ox is, but if you're not, it's just a little device that goes on a finger, and it basically can give us your heart rate and your oxygen sat. And so your oxygen saturation is the level at which you have oxygen dissolved in the bloodstream, and you can exercise. So, in like, say, a hospital setting, we'll say it's safe to exercise somebody when they're like 80 plus in their oxygen saturation, but that doesn't always follow suit with somebody that's PPS, because if again, it's a fatiguing syndrome, I feel more comfortable, and I think the patient's more comfortable if their O2 sats are a little bit higher than that. I'm talking like closer to 90. And I use that as a tool when they're exercising, because it gives me an idea of how fatigued they are. And even if they tell me, like, because again, let's face it, we get these people with personalities where they're like, I can do this, I'm going to do this, and I'm going to push through it. But that might not be the right attitude at some times. So I will use that as a kind of an adjunct and say, well, I appreciate your effort. I think you're doing a bang up job, but let's take a 2-minute rest because their O2 sats aren't where they need to be. And so I try to do it in a positive way, where it kind of says, like, hey, I'm acknowledging how hard of a worker you are, acknowledge how well you want to do, but we should pay attention to where our body is. So that's a great tool. So that's not a bad thing for patients to have, even if you bought it for yourself and you monitored your O2 sats at home with exercise. You can buy them online. You can get them from Amazon and stuff, and they're just another tool that you can use. So that's something I use often. And then perceived exertion scales, certainly, like, if you have a 0 to 10 scale, maybe I don't want you going over a 3 or a 4, in terms of perceived exertion. Basically, I always tell patients, if you can't maintain a conversation with me, then you're working way too hard. So we need to back it down, because you should be able to maintain a conversation with me. And then simple things, I touched mainly on the lower body, but the upper body is important too, obviously, and people are affected in the upper body. And in probably in all of these facilities that you guys have been to, you've seen an upper body ergometer, or UBE, or some people might refer to it as an arm bike. Arm bikes are great. They really are a great piece of equipment, and you can use them for the upper body, bearing this in mind. We know from cardiac rehab that in cardiac rehab, you see new steps all the time, and people use new steps a lot as warm up in physical therapy. That is less fatiguing than a UBE. A UBE, you're using smaller muscle groups, right? And your cardiorespiratory system has to work harder to replenish those smaller muscle groups, because they fatigue quicker. So you have to be very careful. Like in cardiac rehab, we're very judicious about how we prescribe the UBE to people. You'll see all the time them on the new step, but the UBE is a little bit more judicious in the way that it's prescribed, because we know it's going to increase cardiac output. So just be careful with the UBE. I mean, it's great exercise for sure. Again, if you're paying attention to your perceived exertion levels, and maybe you have an O2 sat measurement pre and post, and you compare them. So again, that's a great exercise to do if your upper body is involved. The other things too with the upper body is the pool. Again, back to that, is a great place for your upper body to be used. You have, instead of using like dumbbell weights on land, you'll see these flotation devices that look like dumbbells, and sometimes we have people move through the water with them. And then if your limb is involved quite a bit, we'll actually use an assisted device where you hang on to it on the surface and you kind of just move your arm across the surface of the water or forward and backwards. And then we might carry that over onto land where you're using a TheraBall and you're kind of rolling the TheraBall out away from your body, then back towards your body. So it's giving you a little bit of stability, but you do get range of motion in your shoulders. And believe me, your joints, just because you have PPS, your joints still need movement. That's how our joints stay healthy. There is no blood supply to articular cartilage. Articular cartilage has zero blood supply to it. The way that it stays healthy, think of it like a sponge in a bucket of water. Your capsule to your joint is like a water balloon. The interior of that capsule has cells that produce synovial fluid. That synovial fluid has nutrients that feed your cartilage. So if your cartilage is like a sponge in a bucket, when you don't have pressure on that, it soaks up the nutrients. And then when you are contracting or you're doing a movement, that cartilage gets compressed slightly because the active muscle movement, and then the fluid squishes out from the cartilage. So it's kind of like that sponge being sucking up water in a bucket, and then you're squishing it out and you're sucking up. And that fluid exchange is what keeps your cartilage healthy. So it's not good to stay static for too long with no fluid exchange. And it's not good to be on your feet all the time, and then you're in that compressed state, and then you have no fluid exchange. So the key of that is appropriate, non-fatiguing movement, right? So continuous movement. It's a good idea to move those joints to keep them healthy. That's all there is to it. Because it just doesn't have a blood supply. And then, I when I owned my clinic, we would have a couple of so there was 5 original families that did Tai Chi, right? And so those 5 original families, there are descendants that have come to the United States, and we were lucky enough to have one of the descendants of the 5 original families that developed Tai Chi to actually do Tai Chi out of our clinic on the weekends. Now, if we had somebody that was managing PPS and they wanted to join the group, by all means do it. But you do have to modify it a little bit. Tai Chi it's considered the oldest martial art, but it's nothing like you're thinking in martial arts where kicking and punching and all that kind of stuff. It's a progressive weight shifting. It's more of a fluid dance in martial arts. So for people that were high functioning, sometimes they could participate in that. Other times we would have them sitting in a chair and doing things with their upper bodies. And that was perfectly fine too. And that's the same thing with yoga. Yoga can be taxing, believe me. But if you do a version of chair yoga, and we have done it with people who loved it and thought it was great. And if you have somebody that is well-versed in managing post-polio syndrome, you can do components of either of those type of treatments very, very well. As long as you have somebody that's articulate and well-versed in choosing the exercises for you and how you do the exercises. Because again, it's about joint preservation and not overtaxing yourself. So I hope that helps to answer a little bit. And I think we have a couple more from Friday. And I know I'm so wordy. I know I get accused in the clinic all the time of talking too much. So certainly if you need me to stop talking so much, I certainly will. But
I thought maybe next we'll go to Sandy. Since Sandy's raising her hand, she's been here. She's here live.
Maybe. Oh, I'm sorry. All right.
No, that's fine. Sandy, we'll just take a live question. We don't have to, but yeah, Sandy, if you want to go ahead.
Can you hear me?
Yep.
I think okay.
I can.
You've pretty much answered a lot of my questions. In fact, what you said to and I don't want to make you repeat everything you said, but just one very simple question. Okay, about 10 years ago, well, I think it's simple. About 10 years ago, I did a lot of pool therapy stuff. And I was working with a therapist. My thing was similar to some of the other people here. I did more damage than good. Unfortunately, at the end of about 6 months, I actually lost muscle in my leg and it's never come back.
Okay.
So to be honest, you've talked a lot about flotation.
Yes.
So I live most of the time in Palm Springs. and the pool is like 30 yards from my back door. I
Oh,
actually walk that far.
wonderful.
That's about as far as I can walk if I'm lucky.
Okay.
I've been almost a little afraid to go back to pool therapy because of that. I'll be
Yeah.
really honest. And some of it has to do with fatigue. You know,
Right.
thought of actually putting on a suit and walking out there sometimes is more than I want to do in a day, even though I'm still ambulatory.
Right.
Um, so I guess my question, I'm leading up to a question.
Sure.
For somebody like me that I get up in the morning and I'm stiff as a board, and after about an hour, I'm okay and I can move around. I'm in my office, I work, I drive, I do all, I walk maybe 10 yards at the I'm not very far. Um,
Okay.
I use electric scooters and power chairs.
Okay. Yeah.
What benefit, but my pool is right there and it's Palm
Right.
Springs.
Right.
What benefit would I get from that as opposed to just moving the way I normally move? And I'm sedentary, but I do stretch and that kind of stuff outside the pool.
Right.
Is there some advantage to just maybe walking in the pool? Would that be better for me?
Yes. Again, everybody's an individual, right? So for most people, I would say yes.
You're
There
cutting
are
out.
a few people that will get in the pool and they'll say things like, "Hey, I was overtaxed in the pool and things did get worse." I've heard this in the past. Brian, do you notice any difference? Am I okay?
Yeah, you're fine.
Hello?
Yeah,
You
that's
got a little
better. It
choppy
was.
just for a second, but you're fine now.
Yeah.
Yeah.
Oh, okay. Okay. Sorry, guys. So like I was saying, as I think in the past, some people have reported that they've gotten worse with pool therapy, and that comes down to, well, what's the level of fatigue when you're in the pool and the level of work? You sound like a very intelligent woman. You sound like you're very motivated. I would be fully confident that if I said, "Hey, I think this is great for you to go back into the pool," I think you'd be able to manage it without further wasting or muscle loss. If you follow a few key principles that I've been kind of reiterating, is again, what's your level of fatigue? What's your how much can, because everybody is familiar with themselves and can determine, like, hey, I know where my limit is. And if you're not crossing that threshold, you're probably going to be okay. Now, again, depending on the depth of the water, the temperature of the water, those things in themselves can be fatiguing. So set yourself up right. Make sure that pool is like 90 to 94 degrees. And then, if that pool, like if you needed more flotation and not as much compressive load, you want to go in a deeper pool. But if you wanted to actually try to exercise a limb without as much resistance, then you're going to want a more shallow pool, right? So it just depends on what your goals are, your end goals are. So I would say that you probably should give it another shot, because maybe those principles just weren't quite followed the way they should. And as we're talking about it now, it'll be fresh in your mind and something to try again. And believe me, all of us have had an experience where we've given a patient an exercise and something wasn't right that day and it didn't work out well for that patient. But then we said, all right, let's shelve that for a little, or table that for a little bit, and then we'll come back to it in a month or a couple weeks. And that patient tried that exercise again and was like, "Where's that exercise been all my life? It was great." And it was like, "Don't you remember we tried that a month ago and you absolutely hated it?" So, so I really think that there's a lot of benefit to walking, and if you can do something that's going to be less compressive, less loading for you, I think you should give it a try again. I really do.
Okay. Okay.
I
Thank
don't know
you.
if, yeah, and I don't know if I didn't answer your question fully,
No,
please let me know and I'll try to answer it again. But,
no,
but
you
I
you did
certainly
answer.
think that, okay. I think it's a great opportunity getting in the pool. And since you have one available to you, that couldn't be a better environment, right? As long as they maintain that. And I'm sure in your neck of the woods, the weather is usually pretty good. And so I'm sure that's a pretty warm weather pool. I mean, it's not too cool, right? Because that'll
No.
fatigue you immediately if it's too cool.
Right.
Okay.
They,
Okay.
no, you did answer my question because my goal really at this stage of my life, I mean, I'm 81 years old,
Yeah.
but my goal is to the little bit I walk, I don't want to lose that little bit of being able, even though it's not much, that little bit of
100%.
walking is kind of the difference between being able to live alone or
Yes.
not live alone. And so it's really important. I just want to continue to be able to walk.
I
So if walking in the
yes.
water is going to help that continue, that's what I needed to
Yeah,
hear. That's what I need to hear.
I 100% agree with you, and I would say number one, you look great for your age. Holy cow, lady!
Thank you.
But number maybe that's where we need to live. Uh, but
Stay out of the sun. Keep your face out of the
yeah,
sun.
right. But that said, you also do have to think about, not only am I dealing with post-polio syndrome, I'm a human being dealing with post-polio syndrome, which means you have other things you have to consider because that's going to be the overarching thing in your life that you're always thinking about. But you also have to think about osteoarthritis and that kind of stuff, and heaven forbid, you're always in a progressive weight bearing environment on your good limb and you wear that completely out. And then they say, well, the only thing we can do is a knee replacement. Well, where does that put you? Right. So I would say unload it, get in the pool and unload it, because you can accomplish what you need to accomplish, but you can do it so that you're preserving the joint and the other limb, is what I would say. Okay. All right, Brian, is there anything else? Anybody else?
I think that was the only one with their hand raised. Yep.
Okay.
I think we're pushing right up here on the hour mark, though.
I really got too wordy, didn't I? I'm sorry.
Oh, that's fine. No, it was great. I learned a lot listening to you. I hope others did as well. Um, so again, I just want to thank you for joining us. It's great to get a perspective of a physical therapist.
100. Yeah,
Yeah,
it's my pleasure. I enjoy being here and advocating for the profession and then for people that are dealing with things that, if my own family members were dealing with it, I'd want somebody that was that invested. Right. So
yeah,
find yourself a therapist that's that invested, that you would be their parent or their spouse or what. I don't think there's too many therapists still working at that age, but in general, find somebody that's very invested.
yeah,
Right. So
absolutely. Yeah.
take this from our discussion: reduce discomfort, correct faulty movement patterns and biomechanics, increase your endurance and mobility in a safe, non-fatiguing way, and then have fun with it and build some confidence. So I think that's the takeaway from all of this.
Yeah, fantastic. Again, thanks for joining us. We will be posting this on our YouTube page and on our website. So we
Perfect.
will send out the link to that later. If anyone ever has any questions, if whether it's for a physical therapist or for a physician, you can always go to our webpage. Right on the homepage of post-polio.org, there's an Ask the Doctor button. You can submit questions that way, and we'll be more than happy to answer your questions when they come in. So again, if we didn't get your question today, I apologize, but again, I will try to address those separately. And I want to thank everyone for joining us today. It was a great turnout. And thank Eric for joining us. And we
My
will
pleasure.
be back next month with another Ask the Doctor session. Thank you very much.
Thank you.
Thank you, everyone.